Good morning, this is Peter Petros from Sydney, and I will be talking with you today about the integral theory diagnostic system for pelvic symptoms or prolapse causation. But first I would like to thank Professors Jianlu and Zuli Sun for this invitation to address the 19th Peking University Gynecology and Cosmetic Gynecology Symposium, December 9 to 10. The integral theory diagnostic system is the only diagnostic system which can diagnose which ligaments or prolapse are causing the symptoms of bladder, bowel, and chronic pelvic pain. It is the only one in existence. As such, it can reasonably predict cure or improvement of both symptoms and prolapse and directing surgical or non-surgical treatment. Before we start, a very important point. I want to tell you about the Piscatory Iceberg. Professor Piscatory, a famous colorectal surgeon, discovered that patients generally complain of one main symptom. Many other symptoms are below the surface. So this is called the Piscatory Iceberg. Here. I'll go through that in a minute. Co-occurrence of other symptoms, down here, is extremely important for accurate diagnosis of ligament causation. And these other symptoms must be located by direct questioning. Now, this was from Professor Gershon. Professor Gershon showed 198 women. 198 women came along with only chronic pelvic pain. And then the other symptoms were discovered by direct questioning. So they had chronic pelvic pain and some degree of uterine prolapse. 55 had urge incontinence, 56 fecal incontinence, 68 bladder emptying problems, 127 had frequency, 66 had strength incontinence, 63 had nocturia, 59 had obstructive defecation, and 44 had residual urine greater than 50 mils. The integral theory system for lower urinary tract symptoms and prolapse causation is symptom-based. So we start off with a validated ITSQ, integral theory symptom questionnaire. The positive answers are ticked in this diagnostic algorithm, which has 3 zones: anterior, middle, posterior. Guided by the algorithm, the answers here, whether it's anterior, middle, or posterior, the 3 zones are examined vaginally to confirm damaged ligaments. So the anterior, middle, posterior zones are a little bit different from the compartments. The anterior zone goes from the meatus here to the bladder neck, and it has 2 main ligaments, the pubourethral and the external ligament, anterior to the meatus. The middle zone goes from bladder neck to the cervix, and it has 2 main ligaments, cardinal laterally, and the ATFP. And the posterior zone goes from the cervix to the perineal body, and it has 2 main ligaments, the uterosacral and perineal body. So then, what is unique about the integral theory system, we can actually test the ligaments by mechanical support to prevent symptoms. For instance, we can put a hemostat at the pubourethral ligament, I'll show you that later, and prevent urine loss on coughing, or we can put a speculum in to support the uterosacral ligaments and the urothelial stretch receptors to decrease the urge and pain and chronic pelvic pain. So, in summary, it has 4 elements: a validated questionnaire, the answers are put in ticks in this algorithm, we'll show you that later, the examination, this guides you where to look, anterior, middle or posterior. And finally, we can actually test the symptoms themselves, stress incontinence and urge and chronic pelvic pain, by mechanical support, either with a hemostat or a speculum. So the ITSQ, Integral Theory System Questionnaire, is a validated questionnaire, and it assesses bladder, bowel, pain, prolapse symptoms. So here's the questionnaire. Patient details. The patient explains in her own words what the problem is. And down here, if you look on the left, we have A, anterior zone, and this correlates with the algorithm. A is anterior, which is this part here. M is middle, and P is posterior. Now, the filter, the 50% more in this column, indicates severity. So that impacts quality of life, severity. The red is the symptoms after repair of the pubourethral and uterosacral ligaments. So we'll go into that later. So these are the main symptoms for anterior zone: sneezing, coughing, exercise. And the cause is, according to this, pubourethral ligament mainly. The middle zone, or posterior. Now, symptoms of deficient emptying can occur in the middle zone, either because of a cystocele, or the posterior zone because of uterosacral ligaments. So you tick here, tick in the anterior. Here you tick both the middle and the posterior. So symptoms of emptying, 2 ticks here. Now, the zones, one final thing to explain. The zones are a little different from compartments. So the ligaments fall naturally into 3 zones. The anterior zone goes from the meatus to the bladder neck, and the principal ligament here is pubourethral. The middle zone goes from the bladder neck to the cervix. The proximal ligament here is the cardinal, here it is. And the posterior zone goes from the cervix down to the perineal body. And there are 2 main structures there: uterosacral ligament here and perineal body below. So here's either the questions for urge symptoms. Urge and frequency can be caused by ligament defects in the anterior, middle or posterior zones. Now, the ITSQ have some unique characteristics. It discusses variation about the urge, good day, bad day, and how much pain during passing of urine. That means they could have an infection. Now, nocturia is quite different from urgency. It only occurs in the posterior zone, uterosacral ligament defects. Tethered vagina syndrome is caused by excessive elevation of a birch or scar tissue in the vagina from vaginal repairs. And the characteristic symptom is massive urine loss immediately getting out of bed. Now, you'll see numbers here, 4, 5, 6, 7. These are explained anatomically in the appendix, slide 6. I won't go into them now, but all I'll go into now is the AMP, tells you which zones, which ligaments can cause these symptoms. Here we have congenital. Some children have had bedwetting, and if it continues, generally we find the problem is pubourethral ligament defect, anterior. But when the incontinence starts after the periods, or if women have symptoms before periods, we look for P, posterior, uterosacral ligaments. Bowel symptoms, it can be anterior or posterior. Again, it's explained, A8 and 8B are explained in the appendix. Social inconvenience, well, this goes to how it interferes with a patient's quality of life. So these are standard questions. And again, prolapse, hysterectomy is important. We find that women who've had hysterectomies can have very severe symptoms, especially bowel symptoms after the menopause. Over here, pelvic pain, again, there are 4 main questions here. And as you can see here, this patient, the pain was cured 100%. Usually there is some sort of improvement, not always 100%. And here's a quality of life grading. It's very simple, but it is a very simple quality of life grading. Now, recapitulating, the surgery performed was mini-sling repair of pubourethral and cardinal, and the red writing indicates improvement or cure after the surgery. In the next slide, I'll show you briefly what these numbers are. Every ITSQ questionnaire has an appendix, and these are explanatory notes for the clinician. A, M or P indicate the zone of damage, anterior, middle, posterior. I showed you that earlier. TVS indicates tightness in the bladder neck area of vagina, tethered vagina syndrome. And the significance of filters, none, sometimes, 50%. Sometimes must always be ticked. More than 50% indicates it's quite severe. And symptoms vary. See, sometimes indicates something's wrong. It needs marking as positive when transcribing to the pictorial algorithm. So here we have the numbers, and they explain the anatomical basis of these symptoms. Let's see the diagnostic algorithm. It has 3 zones. I'll go over those again. Anterior zone from meatus to bladder neck, middle zone, bladder neck to cervix, posterior zone, cervix to perineal body. It's a good idea to have the algorithm as a routine part of every patient record. It can be used alone, without the ITSQ, without the questionnaire, as a quick guide to locate damaged structures in the vaginal examination. So you put a tick in every box if the symptom occurs, even if it's sometimes. So for instance, frequency and urgency, here you tick every box. Abnormal emptying, middle can be cystocele, posterior uterosacral ligaments. Nocturia and chronic pelvic pain occur only by uterosacral ligament laxity or damage. Stress incontinence, pubourethral ligament. The ticks also indicate which prolapse. So, for instance, cystocele has only 2 symptoms, emptying, frequency and urgency, and uterosacral ligaments can have all these symptoms. So the combination of symptoms, as we discussed earlier in the Piscatory Iceberg, and you have to ask for all the symptoms, can tell you pretty accurately which ligament is causing the problem. So if you've got pelvic pain nocturia and one of these, you know almost 95% certainly that the problem is from a loose uterosacral ligament. So the examination is number 3 in the integral theory assessment, and this examination sheet ensures systematic examination. So you have to examine every part of the vagina, anterior zone, middle zone, posterior zone. So you look at the anterior zone between the meatus and bladder neck, and you look for, and I will show you this later with photographs, you look for the pubourethral ligament, The only way you can test that is with asking the patient to cough. The hemostat test, I'll show you that later. The suburethral vaginal hammock, and the external ligament. You can actually see all these three things. In the middle zone, the main thing you look for is the cystocele, but you can also look for the cardinal ligament defect, and we'll see that later. And in the posterior zone, we, of course, look for uterine prolapse, enterocele, rectocele, and perineal body. And you should also examine the external anal sphincter. So the anterior zone, from meatus to bladder neck, you look at the urethra. Now that's a normal attachment of the urethra. M is the meatus. But if the ligaments are loose, firstly you get an eversion of the urethral mucosa. You can see a drooping here, and the suburethral vagina H, the hammock, is loose like that. Here you see it's not. Now the hemostat is the only way to diagnose a pubourethral ligament defect is with a hemostat test. Hemostat test, the hemostat is placed immediately behind the symphysis. You put it, there's the symphysis here, you put it behind the symphysis, and what it does, it supports the pubourethral ligament and prevents these muscles pulling it down when the patient coughs. So let me show you this. This is from Professor Palmer. Now the patient's coughing, and the hemostat goes, now immediately, it goes behind the symphysis. Note, there you are, behind. It's supporting the pubourethral ligament, and the patient didn't leak, supported the ligament and prevented the pubourethral ligament being elongated. If it's weak, when the patient coughs, these muscles pull down and it elongates and opens up the urethra. That's how it works. So the middle zone is bladder neck to cervix, and the transverse defect cystocele, when the head comes down, it can break the cardinal ligament, which inserts on the anterior portion of the cervix, and the pubocervical fascia, the vagina, attaches to that. So when this breaks and comes down here, then you can see it here. If you see a patient with the vagina lateral to the cervix, you know that the cardinal ligament's been broken, and that is the cardinal sign of a transverse defect cystocele, and also they've got rugae. This type of cystocele has rugae. So if you look at this figure here, there's a major degree cystocele and fourth degree prolapse. Now, if you have a look at the pathogenesis, the fourth degree prolapse of the uterus is, of course, elongated uterosacral ligaments. But if you look here, you will see the cardinal ligament also has to be elongated. And you can see here, there's the cervix, and you can see that the vagina is going down laterally, as I showed you earlier, and also the whole thing's come out. This patient also has a central cystocele. Central cystocele always has a transverse defect cystocele as well. Now these are what we call simulated operations. We actually test. This is number 4. We can test for the pubourethral ligament defect. I'll show you again. This is the hemostat test. So we put the hemostat immediately behind the symphysis, and it controls the coughing because it controls the descent of the pubourethral ligament. So this is the speculum test. Always examine with a full bladder, and the way it works, it supports the urothelial stretch receptors, preventing the afferent impulses, which are interpreted as urgency, but it also supports the uterosacral, the visceral plexus on the uterosacral ligament, which we have demonstrated are an important cause of chronic pelvic pain. So when you put the speculum in for the pain, it supports these reflexes and stops the afferent impulses, which are interpreted as pain, and it supports the urothelial stretch receptors, which give afferent impulses, which are interpreted as urgency. You can read about it here. So if you look at this examination here, in the absence of perineal support, the rectum protrudes into the vagina to cause low rectocele and perineocele. So when the patient strains, the whole perineal comes down. DPS is descending perineal syndrome. These are the descending rami here, and here are the ligaments, the deep transversus perineal ligaments. Due to birth trauma, these are stretched and elongated and pushed laterally. The perineal body is pushed laterally. So the rectum protrudes to cause perineocele and descending perineal syndrome. Thank you very much.